All right, what's up, CT people? Hope you guys are ready to get your physics on. So for this time around, we're pretty much going to be going through all the chapters that we missed last time. We're going to be doing this week by week, same idea, like chapter quiz, chapter quiz, chapter quiz, and then exam. So it'll be the same kind of thing. Since you guys didn't do clinicals last time, I did put some of these resources here that you guys didn't go through last time, because you're just starting clinicals. So we have week 2 here. This video that I'm recording is going to be under here, and then you're going to have clinical stuff and the PowerPoint and study sheet, and then the quiz. Very, very excited for you guys. I mean, this is going to make a world of difference for you guys to be in clinicals. Really proud of you guys for being patient, sticking through this. So just these 2 quick resources, simple stuff for the first one here. I got a PowerPoint with just CT scanner anatomy. Interestingly, I have a MRI scanner, but you get the idea. In every room, you're going to have these things. You're going to have the gantry, and it's good to kind of know what people call these things. So this is the gantry, the injector, the table or the couch, and then the controls. And then once you go to the controls, pretty much all machines are going to have, they're going to have different buttons, but they're all going to have this in common, where you have an up, that button, up, down, in, out. There's usually a laser button, and then some machines will have a 0 button. This button will zero the centering. It'll zero the position. For example, for GE machines, you have to zero the machine before you can scan. Otherwise, if you're going to tell the machine, I want to scan from 0 to, I want to go up 600 centimeters or millimeters, whatever it measures in. I think it's millimeters. Probably cent. I don't know what it is, but whatever that number represents, where's the 0? Is it the foot of the table? It defaults to something, so you want to 0 it, and a lot of times you can't scan until you do that. Other machines, you don't need to do that. So that's just something. This is something that confused me for a long time, or I keep forgetting it, and you're going to get yelled at. You're definitely going to get yelled at, and you will forget if that's something that this machine needs a 0. So that's pretty much it. There's usually a laser light that kind of shows you for your centering, and that's it for the machine. So you guys are ready to kick butt now. The other thing I want to show you guys is this really handy PDF here. So this is under Clinicals 101 PDF. These are questions, these are just kind of things to go over and to familiarize yourself with clinicals and with everything there. So we had a lot of, I don't want to say trouble, but you know how it is with students and techs. Sometimes it's people are touchy with certain things. So it's always a good idea to ask, do you mind if I check out the machine? Can I go in there when there's no patient? Just go in. If people don't know you, you're new there, and you're just touching their machine, somebody's going to freak out. It's weird, I know, but just humor people, and just if you see somebody there, say, do you mind if I go in? Also, you don't know if they're doing, even if there's no patient in there, they may be doing test scans, like QA stuff. So there may be live radiation in the room. You just don't know. So until you're more familiar with the people there and with the equipment there, definitely ask if you can go in there, and then once you go in there, try to do all these things. So I highly recommend you print this document here. Familiarize yourself with the up, down, and out buttons. Sometimes there's foot pedals that bring the table up and down. Familiarize yourself with those. There's usually a fast table movement button. So there's usually a slow movement and a fast movement. Familiarize yourself with those. The more you're familiar with all of these things prior to a patient being in the room, the more you'll learn. You guys are at a disadvantage, let's be honest, since you guys missed the whole semester. So you have a lot to learn, and the more of this stuff you guys can pack in there, the better. This is not part of my job. I mean, I'm supposed to teach you guys physics, but very, this is a big thing for me because I had a hard time in clinicals, and these things would have helped. So this is kind of what I learned through trial and error, the things that I wish I did. So go in there, ask if you can go in there, play with all this stuff when nobody's in there. Get really familiar. I'm not just saying say, okay, now I know where it is. No, get fast. You want to be just as fast as the techs. It shouldn't be hard for you to know how to press these buttons and do these things when there's no patient. You don't have to know how to scan a patient yet, but you should have no problem being very proficient in the movements of the table after 1 week of clinicals. You should have no problem. So get these things down, understand how the laser works and whether or not you need to zero. And that's pretty much it for the controls. Now next you need to understand the scans. What kind of scans are done? This is something that can be very confusing when you're coming from X-ray. There are different scans that can be done. There's scans with contrast and there's scans without contrast, and then there's both, with and without. Now, you guys are like, okay, Tariq, we already know that. Yeah, but the way the order is spelled out can be very confusing. I have personally scanned the wrong thing before. It happens. It happens. It shouldn't happen. If you're careful, it should not. But I will tell you, it's happened at least 50% of tests. It shouldn't happen. Easy to get distracted. So be very careful. After you're familiar with the machine, start understanding your clinical site. What do the orders say? Do they say W for contrast? Or do they say the word with, or do they say the word enhanced? These are all words that can be used for the word contrast or for enhanced. Sometimes they say contrast, they say with, they say enhanced. So understand what terminology your site uses. For without contrast, do they use WO, do they use plain, or do they use unenhanced? Again, different verbiage. And then for with and without, you'll see these different things. I've either worked or been at clinical sites at Christ Hospital, Palos Hospital, Little Company in Mary, and South Suburban. Everywhere is different. Everywhere is different. You can't, I was a proficient tech. I was literally, head of the CT department at Christ Hospital for my shift. And I went to South Suburban Hospital and it was like starting over. There was, I had to really relearn a lot of things. Different machine, different orders, everything was different. So that's as far as the enhancement of the scans, the documentation. So again, when there's no patient, you want to go in the room, and then also when there's no patient, you want to look at the orders, ask permission. You will get smacked on the wrist if you're touching orders that you're not supposed to be touching, especially when they don't know you. So ask and try to understand what terminology is being used. The scan phases is something you guys are probably familiar with a little bit right now, but understanding when certain phases are done. CT without does not enhance. Obviously, CTA enhances the arteries, CT with enhances the veins and organs, and then PO in contrast is for the digestive tract. So it's a good idea to have the background here. This is really good information. You guys should probably have this with you all the time. Scanning. This is a big one. Does the patient go in head first or feet first? Well, every facility is different and every exam is different. So at every facility I've been, there's no right answer. Sometimes it's like most of the exams are head first, but then certain times you go on feet first. So this is another big thing, that the sooner you learn this, the more you can be helpful. And this one will take time, but I would start to document, which exams go in head first, which exams go in feet first, so that you can be more helpful, be more resourceful, and get in on more scans and get more experience. So these are typically the three big things. For a head, obviously you go in head first. For a chest, are you going head first or feet first? For an abdomen, are you going head first or feet first? If you understand these three, then the rest will kind of come with it. Head holders and footrests. Some of the sites I went on, when you do a head CT, you have to put a headrest on. When you do a body CT, you have to put a footrest on when they go in feet first. So you had to constantly switch them out. Scanning steps. Go through these. This is pretty much pretty universal everywhere you go, but you really want to understand the scanning steps for your facility. Now, this may seem silly, but if you document the process yourself for your facility, you will really learn it much better. I'm not saying do that right now, right away, day one, but after a week or two there, you should have an idea of what's happening. Start documenting it. The first thing you typically do is select the patient off the work list. Next, you select a scan protocol. So you pick, Mr. John Smith, and then we're doing an abdomen CT. So you typically select those things on all different kinds of machines. Next, you want to make sure that patient orientation matches. If you scan the patient when they're head first, but the machine thinks they're feet first, all the anatomy is going to be flipped. It's terrible. You could literally kill somebody doing things that way. So you really want to understand this process. Do not skip this step. It's huge. It's really, really huge. After you've done that, you initiate the scan, and then there's different scan series. Typically, there's always a scout or a topogram or a scanogram. This is just like an X-ray. It's just like a coronal sagittal X-ray where you can map out, and you have your X-ray in front of you. You say, okay, I'm going to scan from pubic symphysis up or whatever. And then you'll either do unenhanced, enhanced, arterial, venous, or delayed scan, depending on what's going on. The machine automatically reconstructs the necessary series, whether it's thin series, so that you can do 3Ds or coronals or sagittals. And then there's window series, soft tissue, bone, or lung windows. All of those should be automatically made for you. And then you typically take those thin slices, and some machines will do it automatically. Other times you have to do it yourself, and you have to create multiplanar reconstructions from those from the thin slices. The thin slices are obviously axial. The machine scans an axial, but then you're going to go in and you're going to scan them from. You're going to reconstruct the images in a coronal way, sagittal way, oblique. You could do whatever. That's pretty fun, actually. And this is something, once you guys understand how to do this, you should do this when there's no patients. You don't have to have a patient on the table to do this, but it is time consuming. I mean, if you work in a busy place, people are not going to want to wait for you to do this. They're going to push you out of the way. So the more practice you get when there's no patients, the faster you'll get, and you'll be a tech in no time. Sending the proper series to PACS. Again, a lot of times, a lot of machines will automatically do this for you, but most of the time you have to select what you want to send to PACS and what you don't want to send to PACS. Why would you not send something to PACS? Well, unlike X-ray, there are certain series, like the thin slices, that give you like 1 million images that the radiologist does not want. Those images were purely there so that you can create different series from them, coronal or sagittal, etc. But it's just going to slow down the PACS. It's going to drive this radiologist crazy, and you will get yelled at for that. It happens, but understanding what gets sent. And again, I know this is kind of overwhelming by this point, but this is a reference for your entire clinical. Okay, the sooner you kind of familiarize yourself with this stuff and get more comfortable with it, this is pretty much by the end you're going to know this like the back of your hand. So at least you want to know what it is that you need to know. It's an outline. Lastly, X-ray versus CT, just knowing the difference so your expectations are met for like the series we talked about. So when you do a PA chest X-ray, okay, there is raw data. Okay, you just don't see it. It's not sent to PACS. You see the raw data for like a split second. That's like that image that's like kind of gray. That is raw data, and it's not sent to PACS. And then it's reprocessed. It's processed, and then the PA chest image, not the raw data, the actual image is sent to PACS. Same thing with the lateral chest X-ray. So you have one series here, one image is taken. The raw data stays in PACS. It's processed. It does not go to PACS. It's processed, and then the processed image goes to PACS. And then you do another series. The raw data stays in PACS. It gets processed, and you send the processed image to PACS. So even though 4 things happened, only 2 went to PACS. It's kind of similar in CT. So you do the scout, that gets sent to PACS, scout AP, scout lateral, gets sent to PACS. And then once you do the scan, we have raw data that is not sent to PACS, just like X-ray. This raw data is just used to be processed. From that raw data, okay, we're going to create different images. Just like from this raw data, we created the PA chest. Again, you don't really pay attention to this, but it does happen. The CT scanner will do the same thing. It'll create different thicknesses of images, and it'll typically do this automatically. It'll change the window and level. It'll do all that, most of it automatically, and then these get sent to PACS. And then the thin slices, it creates really thin images that can be used to reconstruct better images, or coronals and sagittals, but it's not sent to PACS. So this is kind of the difference between a chest X-ray and a chest CT, so you guys just kind of have an idea of how this goes. Go through this, and then go through it again, and then go through it again and again and again, and you will do very, very well at clinicals. This is, a wealth of knowledge here if you guys utilize it properly. As far as the chapter 2, pretty straightforward, really mostly memorizing. I'm not going to sit here and have you guys listen to me read. Just go through the chapter, the PowerPoint, and then go through the study sheet, and you guys should be golden for the quiz. Any questions, you guys notify me. Looking forward to hearing about all your success, guys. Talk soon.